All right, so next up we have Dr. Rabeeia Parwez, who will be speaking about the UK pathway. Dr. Rabeeia graduated with her MBBS from Shifa College of Medicine in 2017, after which she completed her house job and then moved to the UK. Following full registration there, she began working as a senior house officer in neurosurgery at Queen's Hospital, and then later secured a core surgical training post themed in trauma and orthopedics. We're truly honored to have her here today to share her valuable insights and experiences about navigating the UK medical training pathway. Please join me in welcoming Dr. Rabeeia Parwez.
Hi, hello. Thank you, Rish, for the introduction. I am Dr. Rabeeia Parwez, or Miss Rabeeia Parwez, as we like to call ourselves in the UK. Can you see my video and can you hear me?
Yes, we can.
Okay, perfect. Let me start sharing my presentation. I think you are already sharing something, so I won't be able to share. Would you be able to give me?
Dr. Rabeeia, I'll stop sharing my screen so you can share yours then.
Sure, yeah.
You can share a screen now.
Okay, perfect. Right, so are you able to see that?
Yes, we can see.
Right. So as I said, Miss Rabeeia Parvez, over here in the UK, it's kind of like a different world. I think there's a lot of information about securing residency either in different other countries, in your home country or in the US. But I've mentored and spoken to a lot of doctors over the years, and I kind of feel like there's not a lot of information out there about UK. And I think it's probably because there's a lot of different terms we use over here, and also the pathway is a bit complicated. So if anyone is interested in pursuing surgical residency in the UK, I think the first step would be trying to understand how the pathway works, so which is what I'm going to do today. So a little bit about myself. I graduated from Shifa College of Medicine in 2017, did my house job in 2018 and finished around March of 2019 and then moved to the UK. I hadn't given my PLABs yet. So when I arrived in the UK around like 2 weeks later, I had my PLAB 1, and then about a few months later, I had my PLAB 2. Then COVID hit and there was a crisis. They weren't hiring new doctors. So there was a little bit of gap over there. And then I secured my first job in 2021 in Queen's Hospital as a neurosurgery junior clinical fellow. Then spent some time over there, then started locuming full time. And I'd always been interested in surgical training, orthopedics. But there was certain like reasons why I wanted to locum first a bit, and I'll go through my personal journey as I go through the pathway to hopefully make you guys understand what happens in the UK and how you get into surgical residency. So I got into core surgical training the year before, so it's currently my second year now. And let's talk a little bit about how to get into the UK. So the first step is getting your English language test, which would be your IELTS or your OET. And then there's two exams, the PLAB 1 and the PLAB 2. PLAB 1 is an MCQ exam, PLAB 2 is an OSCE-based exam. I would say if you are a fresh graduate right out of your final year, you should be very much able to pass PLAB 1 without a lot of studying. PLAB 2 is an OSCE, and even if you have like good current clinical knowledge, you still need to understand that the UK and the NHS is a system that you can't compare to anywhere else. So there's like certain pathways and things we follow, especially because it's a free-for-all system. So at free at the point of access, no one gets charged in the NHS, unless of course you're a tourist or you're not from the UK. So due to some of those reasons, the system in the NHS is quite different, and the OSCE reflects that. So knowing the pathways really helps you score well in PLAB 2. PLAB 2 is an exam that's only held in the UK. So you're not able to do it anywhere else, and it's only held in Manchester, in the GMC building in Manchester. So that's why it takes a little bit of time to get a date for your PLAB 2. Provisional versus full registration. So you get full registration if you've already done your house job. You get provisional if you haven't done your house job. If you finish PLAB 1 and PLAB 2, you pass them, you can apply for provisional registration. So you can apply for F1 jobs, but you can't practice independently in a way that you can apply for anything other than F1 job. And then again, F1 and F2 are terms that lots of people don't understand, but I will go through them, all of them. So majority of the doctors who are international medical graduates usually come after they finish their internship or house job in their home countries. And they work as an SHO equivalent, which is anyone who's finished the internship or house job the first year after they've graduated. Anyone after that is technically called an SHO or a FY2, or there's many different terms you can use for it. And registrar is someone who's finished, the first few years of your training and you finished your exam. So in surgery, you give your MRCS over here, membership of Royal College of Surgeons exam. Once you've done that, you can apply for a registrar post. There's a lot of discussion, and a lot of the questions I get from people who ask me about the pathway to UK residency is if they should apply directly as someone who's never worked in the NHS before. And the answer is no. So it's really not advisable, but still, like, thousands of people do it. Not so much in surgical training, but a lot of people apply for GP training, IMT, medicine training, or any other training. It's not advisable because usually the doctor, the UK graduate, when they are going into training, they have already done the first 2 years after they've graduated. So they are well aware of the system and they know how everything works. And when you are a trainee, you're someone they expect to have at least 2 years of NHS experience. I'm not talking about just clinical experience, but specifically UK experience. And you will be responsible for the junior members of your team. And if you don't know how the pathway works, how the system works, all of that, it does turn out to be a problem. And I have seen a lot of people who have had trouble progressing in their training because of this. And also, you can be referred to the GMC and your license can get into trouble if you make a mistake, even if you didn't make it deliberately. So again, that's not advisable. I know in the US it's different and people always like to compare the UK to the US, but it will be really helpful if you think of UK as a completely separate country, which it is, and the system as completely separate from the US. We take nothing from the US. Even the culture is completely different. So a little brief overview of surgical training in the UK. So you start from medical school, which is 4 to 6 years. The reason I say 6 years is a lot of people over here do a BSc alongside their MBBS. So that's an extra year. Sometimes they'll do another bachelor's. Once they've graduated from medical school, they'll do a foundation program, which is 2 years. So like from my home country in Pakistan, we have 1 year of house job, and then you can apply for independent practice or whatever you want to do. But over here, you have 2 years, and you have to complete those 2 years before you apply to surgical or any kind of training. So as you can understand, if you're applying for core surgical training, the other people, the UK grads with you, would already have 2 years of experience over you. Applying to core surgical training comes after foundation year, or for IMGs, it'll come after you've done your house job in your home country and maybe gained some experience in the NHS. I would say at least 1 year of experience in the NHS should be mandatory, where you spend some time trying to learn the system. So core surgical training is a 2-year residency program, which it has about 600 jobs nationally all over the country. And instead of applying to hospitals, we have something called the national selection, where everybody applies to the same system. And we then go through our whole process where we give an exam, we upload our portfolios, which should be we're already given guidance of what to upload, but we upload our portfolios and then we go through a very strict online interview. And only after that you get your rank. So nationally, everyone who applies. So I think this year the competition ratio was 9 people for every job. So you're competing against at least eight other people for the same job. And then there's certain areas like where I am currently working or anything in or around London, which are very competitive. So again, it's more difficult to get into those programs. So you have to be like in the top 10, 15% to secure a post over there. So that's 2 years of core surgical training. These jobs are team jobs. So if you know that you want to do orthopedics, you want to do ENT, plastics, whatever you want to do, these are team jobs. So my current job has 6 months of general surgery and then 18 months in orthopedics. And those 18 months at the moment, majority of your time is spent in theater, so operating. And they try to get you ready as a registrar, because as a registrar over here, you are technically the senior most person in the hospital, especially overnight. So the consultant might be at home and you are there to offer advice. Of course, the consultant does come in if they need to, but that's something you are preparing for in the first 2 years. And then higher specialty training, or what we like to call ST3, so core surgical training. The first year is called CT, so core trainee 1, and the second year is core trainee 2, so SCT2. And then you apply for ST3, so that's basically the third year of your training, and you have to apply again. So a lot of people ask, and I can understand, like even I feel like that it's quite unfair to apply again, but there's a huge amount of people who drop out of surgical training, especially in the UK. So there are certain jobs which are run through where you don't have to apply again, and the majority of those are in general surgery. But for every other specialty, you'll have to apply again at ST3, and then ST3 up to ST8, so that's 6 years of registrar job training. After that, you CCT. CCT means a certificate of completion of training. Basically means that you're done with your training and now you can practice as a consultant if you get the job. On the side, they have something called academic clinical training and out-of-program experience. So let me explain a little bit about that. When you apply for core training or higher specialty training, there's a separate application for people who want to go into academics. And they have the same process. They go through everything that someone applying for core surgical training goes through, but they are graded based on how much academic work they've done, how many papers they have, and things like that. And if they get the job, then they have certain blocks in their training that are kind of reserved for them to do academic work. And these jobs are based in big academic centers where there's a lot of research going on, which will obviously help them further. Out of program experience, what that means is there is a way to kind of pause your training. So a lot of surgical trainees either do masters, PhDs, research, whatever you can think of. And you speak to your supervisor and your program director and you ask for a pause in your training and you tell them, okay, this is an opportunity that I want to pursue, such as a PhD or something. And they say, okay, we'll pause your training for 3 years so you can finish your PhD. But just so you know, it's not just for academics. So there's different terms used for it, but it's all out of program experience. And for example, if you are a woman and you have had kids and you want to take some time away from training and focus on your family, you can do that as well. You can pause your training for a year or 2 years, focus on your family, and then come back to training. So that this, in the UK, I think it's really very family friendly, especially, training, medical training. They try to do their best to make sure it's accessible for everyone. So what a fellowship means is, I think we're all aware of what a fellowship is. After you finish your training and you want to go into a subspecialty or you want to gain more experience in something, you apply for a fellowship. So for example, in orthopedics, if you want to go into spine, you do a spine fellowship where the nature of the job is basically 1 year, but you are specifically attached to a consultant who is let's say, a spine specialist, and you'll only be operating on spines, and that's all you're going to do. So that fellowship looks really good on your CV. And then if you want to apply for a job that's like an ortho spine job as a consultant, they would prefer you because you've already done a fellowship and you've gained a lot of experience in that area. And in the end, consultant, you can either be an NHS consultant, you can go into academics. So if you've already done academic clinical training, but it's not just reserved for someone who's done academic clinical training. It also depends on your CV as well. So if you've done a lot of research and you're interested in that, you've done a PhD, MD, anything, then you can apply to academic center and get accepted as a consultant. What does it mean to be a specialty doctor or associate specialist? So these are jobs where you are like you have your own patients and you are basically operating independently, having your own clinics, but you are not a consultant. So let's say you are not on call as a consultant and you don't have patients who are admitted under you. The reason this job is there is because, well, we have a lot of waiting times in the NHS, basically because it's free. And there's a lot of people waiting to have surgery. So they do the job, they operate, they do their clinics, but they don't want to be they don't want to have the responsibility of being a consultant. Many people prefer doing that because you get to do the job, you don't have like the downsides of being a consultant. And also, if you've not done training, but you've gained enough experience that you are equivalent to someone who's trained for 8 years, then you can apply for these jobs and be accepted based on your portfolio that you've accumulated over the years. There is one other thing we have a term for. So if someone doesn't want to go into training, or if someone was not able to go into training, we have things called non-training jobs, where you are doing the same job, but you're not getting trained. So there's no career progression. And some people choose that deliberately. And what they do is they keep a portfolio and they keep a log of all the theater procedures, every presentation, publications, everything they've done. At the end, they go to the GMC and show them their portfolio and say, well, I think I've done enough that I can basically I can work at the level of a consultant. And they do something called a CSER. So it's called a CSER, CESR, which is equivalent to a consultant or a specialty doctor. And they're put on the GMC register as someone who's done their training. So essentially, they can apply for consultant jobs, but a majority of them don't get them because they prefer someone who's gone through a formal training pathway. But I mean, certain centers do accept people who've gone through CSER, and they do accept, give them jobs. Majority of them go as a specialty doctor. So there's so many different pathways, and I know at the end of this, everybody is very confused about what this is. But if you're in the system, and this is one of the reasons why I say, you need to gain some experience in the NHS to understand what's going on. But at this level, what's relevant is that gain some experience in the UK for at least 1 year, and then apply to core surgical training, which is basically where you start your surgical training. So I'm going to focus my presentation on core surgical training, so it's easier for everyone to follow. So core surgical training has 3 components to it, the application process. The first is you give an exam, which is called the MSRA exam. It's a multi-specialty recruitment assessment, and it's a computer-based exam. It has 2 parts: professional dilemmas and clinical problem-solving papers. The MSRA exam is not just for surgical training, it's also used for GP. It's also used for psychiatry training. It's also used for obstetrics and gynecology, neurosurgery. All of these specialties use the MSRA, and your score determines if you will get an interview or not. So it's not just an exam that you can take lightly. You have to prepare for it. The problem, especially for surgical specialties, is this exam is actually quite focused towards GP. So a GP job or a psychiatry job. And so the content that you're being examined on is something that a GP should know. So there's very little surgery or anatomy in this exam. But anyway, that's how they've decided to make the process for us. And you just have to study for the exam and give it. The exam can be given from, I think, anywhere in the world. So it's open for all. And usually you prepare from online question banks. Now, I prepared a lot for this exam. I prepared properly. The reason lots of people don't do well in this exam is they don't take it seriously. They think it's a GP exam, so it's not that difficult. But if you spend time in surgery, I don't think it's like feasible for you to keep your knowledge up to date in a lot of like medical, psychiatry, GP things. So you'll have to revise all of those again. And the really difficult part for IMGs where they struggle is the professional dilemmas. So the professional dilemmas questionnaire is basically something that's very targeted towards um, the UK system. So if you worked in the NHS before, it'll be easier. But again, it kind of self-selects towards UK graduates. So if they've already been in the system for a long time and they know how like the culture works. So they are better, they score better in this part of the exam. And it's usually this part of the exam where IMGs struggle. So, I mean, we all have good clinical knowledge. I don't question that. But again, professional dilemmas is very focused towards the UK system. Um, there's lots of online question banks available. So, you choose one and you just, start preparing for it. Essentially, that's how you do. A little bit about what core surgical training is and what ST3 is. So a lot of the international medical graduates that contact me ask me if they should apply for core surgical training or they should apply for ST3. So basically, CST or core surgical training is something that someone who's fresh in their career or they haven't done a lot of surgery should do. So there is actually this caveat that if you have more than 18 months of surgical experience after your foundation year or your F1 or internship, house job, whatever you want to call it, then you're not eligible to apply for CST. So basically you're overqualified. So they won't let you, they'll reject your application. But you can still apply for ST3. The problem for specifically this is if you are in a non-training job, let's say, okay, you didn't get into CST and you applied for a non-training orthopedic job as a SHO in a hospital, then it's a bit difficult to get into ST3. It's not that people don't I know of a lot of people who have gotten into ST3 from a non-training job, but the benefit of being in a core surgical training job is there's a lot of oversight in your training. Like they have to train you whether they like it or not. They have to give you time off for the interview. They have to prepare you for the interview. They have to like basically do everything in their power to make sure that you are going to get that ST3 job. If you're in a non-training job, they have no, they will just give you the basics. Or if you have self-motivation, then someone might try to teach you or try to help you with the interview, but it's mostly just you and your own motivation. ST3 ends with a CCT. CST is just the first 2 years, so you still have to apply for ST3. But again, it depends on where you are in your career and how much experience you already have. That's what basically decides which one you're going to apply to. So I hope that is clear to everyone. And what do we mean by non-training and training jobs? So training job is basically either CST or ST3 or registrar or that line of work where it's ST3 to ST8 for 6 years of registrar training. So over here we have non-training jobs. Essentially, you can work at the level of a CST and you can work at the level of a registrar, but you are a non-trainee. So what that means is you will be doing service provision. So you'll be on the wards, you will be doing discharge summaries, you will be operating, you will be doing all of that, but there is no career progression. Unless you want to progress, and you will have to find your own opportunities, but majority of the times they will not be very inclined to let you progress because they are happy with the way things are. there's no oversight to your training. So even though they do say, oh yes, we will teach you, but it's mostly just, as long as you're doing the job on the ward, they're happy with that. They don't really have any benefit in teaching you, basically. But if you are in a training post, then you get paid. You have courses that are paid, that are free basically for you to do. You have interview practice, again, free. Your career progression is all evidence. So there's an ICB we have an online portfolio where we have to upload everything, and there are people who sit and make sure that we are uploading and progressing in our careers. If there's problem, for example, if I don't get enough theater time, if I'm not getting enough clinic time, I can let my supervisor or my program director know, and they will do everything in their power to make sure that I am getting what I need to progress in training. So there is a lot of benefit in being in training post, but there's, a lot of people either don't get it, especially because it's quite competitive, or because, they don't have the correct mentorship, I would say. I was lucky in the sense that I did get good mentors, and I was given opportunities, but I would not say that it was because there were good people around me. It was also because I was quite self-motivated. I wanted to find out these opportunities for myself, and so it's a little bit of like both. Making sure you have the right people guiding you, but also make sure that you are in the right place at the right time. You're good at your job, and you are dependable and also likable. So people will be giving you opportunities and putting you forward for things, helping you with the interview and things like that. Especially as IMGs, I think a lot of like the soft skills we're not taught, or it's not something we focus on. Maybe we are taught. But interviews, practice giving interviews, all of these things, this is something that you need to learn. It doesn't come naturally. So find out the right mentors, and make sure that they give you the time and the training to be able to do these things. Once I've gotten CST, I'm always like open. I try to speak to as many IMGs as I can, and in the end, I've given my details. So if there's anyone who would like any like specific questions or some specific mentorship, I'm always open to that. I think we should be helping people get into surgery. Again, when you want to do surgery, I think a lot of people try to discourage me, and it's something a lot of people face as well, more so women than men, that, why do you want to do surgery, or don't you want to have a family or whatever. But I feel like, if this is something you want to do, then you will do it at the end of the day, and, stop listening to people who try to discourage you. That's the only way to progress. So this is a question that I get very, very often. Why is training so long in the UK? So the biggest question is, why not? So the reason training is short in other countries and so long in the UK is because we have something called the European Work Time Directive, which is basically, in summary, this thing where we can't work for more than 48 hours per week. That doesn't mean we never work more than 48 hours. It basically means that on average, I think over 6 weeks or something like that, we can't work over 48 hours per week. So some weeks, if we work 72 hours or 80 hours or whatever, then the next week we'll get a lot of time off. That's essentially what it means. Over here, the culture is very different from America. We get sick leave, we get maternity leave, we have a work-life balance. People don't mind if you don't reply to emails or text after you're off work. People have a life outside of the hospital over here, and everybody's very protective of that. We have many things. You can like complain if you're frequently staying back at the hospital, and if you are, like for example, you've stayed back half an hour, maybe because you were operating, you can raise a ticket, or you can data it in a sense, and you can get paid for your time, or you can get a day off because of that. So essentially, this is pretty much the reason. In some ways, it is also bad, especially because if you want to be a surgeon in surgical training, like we have certain targets we have to meet, like I have to do, I think, as a CST, a minimum of 120 procedures per year. And half of them should be something that, I've done, and the surgeon, my supervisor, is scrubbed in with me. But if you have a lot of time off, then it's a bit difficult to get all those numbers. And even if, like, you essentially want to be operating more than that to be able to call yourself a good surgeon. So there are people, a lot of surgeons, who do come in their off days, me as well. But it's a choice. It's not something someone will force you. You can come in if you want to, and you cannot come in if you want to. So it's completely up to you. There are things called less than full-time training. So what that means is essentially, for whatever reason, majority of the times, usually because you're a young woman and you've had a child recently, you can do something called less than full-time training. So it's either 80%, 60%, something like that. So 80% is basically you get 1 day off per week, and you get the same day off generally. Currently, I'm doing less than full-time training, and I have Mondays off every week. So that really helps with having some kind of balance in your life if you have a young child, and at the same time progressing in your career as well. Over here, training is competency based. So even though it says surgical training is 8 years, but less than full-time training essentially means that you're going to spend, less time in training than other people. But if you're reaching your competencies, then they won't extend training time unless they need to. So before I went into less than full-time training, I had a chat with my program director, who went through my CV and said, okay, your essentials are MRCS, you've already passed that, you've done your essential courses, one of those courses is left. All you have to do is like make sure you have like continuous assessments at work, and you are hitting your targets as a surgeon, theater time and operating as much as you can. And if that is met, we won't extend your training time. So again, there are certain things like this that makes it quite attractive to train in the UK, because essentially you do still have a life outside of the hospital. And then there's a lot of surgeons who do want to go into academics, and then there's certain specialties, cardiothoracics, neurosurgery, general surgery, certain specialties like colorectal, which are very, very competitive, especially at the level of a consultant. And in a lot of ways, a PhD or a master's or something specific like research in that area will push your CV forward and help you secure a consultant job. So there are a lot of people who do that. So even if training is 8 years, they'll take 3 years out and do a PhD. So it takes even longer. But over here, no one actually cares how old you are when you're finishing training. So I mean, the culture is very different over here. So no one ever says, "Oh, you're too old to start training or finish training or whatever." Consultants usually are of an older age than I think in other countries. So commonly used terms, I've already gone through this, so I won't talk about this much. How to apply to surgical training. So I had the page open, but if everyone, if you want to look into this, it's Core Surgical Training Self-Assessment. If you Google this, there's a page from Health Education England, which goes into a lot of detail about exactly what you need. But essentially, it's all of these things, and they grade you on how much you have. So surgical experience, for example, I think the top grade or the top marks for surgical experience is if you've done 40 cases, and you need to submit your logbook to show that you've done 40 cases. Commitment to specialty, things like a taster week in a surgical specialty will give you marks. Audits is something I think it's quite UK specific, but basically measuring some process in your hospital, like and comparing it to a national process, like a national guideline. And if you've done an audit, you've led it, you've done majority of the work, then you get the highest rating, but it should be in a surgical department or a surgical topic. Publications and presentations, highest marks is essentially for original research paper that's not a case report. Presentation essentially needs to be either national or international. teaching experience, in teaching experience, basically you have to do a teaching program where you can teach, different cohorts, either medical students or your colleagues, but you have to do at least 4 of those sessions. And then leadership experience. So this isn't counted in your portfolio, but essentially the interview starts with a 3-minute speech on your leadership experience. So if you have something to talk about, it's only then that, your leadership experience will count. Courses and conferences don't count anymore, but they used to. But I've added this here is because, if you're in med school, essentially this is something you should be able to, start doing. You don't really need anyone to help you with this. So this is basically what the portfolio is and what you need to work towards to be able to go into core surgical training. Look at the criteria and start aiming for that if this is something you want to do. Right. So this is a slide about my own personal experience, and I wanted to talk about things that I have experienced myself and why it took me a while to get into surgical training. And also, I think it resonates because a lot of people, when they do these presentations, everyone's talking about everything, they've done really well. And I think as a med student, I remember not being able to relate to them. So when I was in med school, I didn't really know what I wanted to do. I enjoyed medicine a lot. And I always thought I would be going to into internal medicine. Then when I came to the UK, I essentially realized that medicine is not something I want to do. I didn't really enjoy it in my house job either. And surgery was something that I felt like, these are my people, their personalities, and it all resonated with me. I started neurosurgery here in the UK, and I really enjoyed the fast-paced nature of the job. I really enjoyed the aspect of being able to heal someone. I felt like in medicine, you give a lot of medications, and then in the end, there's not much difference. But in surgery, you see the difference really quickly. And for me, that was very satisfying. So I decided to apply to core surgical training, but I essentially didn't have much on my portfolio, and there was no guidance. So So then, self-motivation, I had to teach myself a lot of things, what to put on my portfolio, how to start doing research, audits, all of this. And then I was in a non-training job in neurosurgery. So when I say avoid the non-training job trap, what I mean is essentially they need you for service provision, discharge summaries, cannulas, catheters, NG tubes, all of that, arranging scans. It's a difficult job. But then you don't have much time left to work on yourself, your portfolio, publishing things, going to conferences, doing courses, essentially progressing in your career. And a lot of IMGs, when they come to the UK, they have the same problem. Even recently, I was speaking to someone who wanted to know what I had in my portfolio. And I said, how much experience do you have in the UK? And what do you have on your portfolio? And they essentially didn't have much, even though they had about 18 months of experience in the UK. And I think that's a problem. We come here and we try to understand the system, try to fit into the job, and we get very busy trying to be good at that job. And we forget to put time towards our own portfolio or work on our own selves. And then you essentially kind of realize, oh, I'm overqualified for CSE. And then ST3 is something that's even more difficult to get into. So then you have to essentially start working towards ST3. So that's one of those things where I always advise people, like, no matter where you are, whether you're in med school, you're in house job, or whatever part of your career you are, always make sure that you are progressing in your skills in some way or the other. Make sure you put your finances and your time towards that. and then utilize your time and your day. So basically, in the beginning, I felt like getting into UK surgical residency is quite difficult. IMGs barely get into surgical training over here, especially because it's quite competitive, and obviously UK grads would essentially do better at the exam, and it would have better portfolios because they know about what to do since med school. And a lot of people discouraged me as well that surgery is essentially really difficult to get into, but um, you won't know till you try. So I thought, I'll try my best. And then I got, help from colleagues, good mentors, and essentially just kind of, I didn't know, like the first time I did audit, I had no idea what I was doing. The first time I wrote a paper, I had very enthusiastically signed up to write the paper, but I had no idea what I was doing. But I figured it out. So I think like having that kind of personality really helped me because I would say yes to everything and then I would sit down and figure out how to do things. But I did, and I mean anyone can do it if I can do it. So I really like, self-motivation is something that's going to help you no matter where you are in your career. Ask help when you need it. So if you feel like, you're not getting the right mentors in your location, then look online, it's a digital world. Find out people who are like-minded or, look at their portfolio and think about like, this is what I want to do in my life and ask for help, ask them how they did the things that they did. And then critical self-appraisal. So think about like if you're not progressing in your career, if you're not going in the direction you want to go, then essentially just sit down. So that was one of the reasons why I left my job in neurosurgery and locumed for a bit. Essentially, I wanted to get into core surgical training. I hadn't applied because I felt like my portfolio wasn't good enough. My portfolio was good enough, but I just felt like there were so many people discouraging me basically saying it's next to impossible for an IMG to get into surgical training in the UK. And then I spent some time locuming because over here there's a thing where you can locum. Basically, it means that you are not in a regular like full-time paid job. You work when you want to work, and there are shifts. So if there's like someone who's called in sick or if someone's resigned and there are certain like shifts available because they're understaffed, so they pay quite well. They pay about like I think at SHO level they pay about 55 pounds per hour. So essentially, if you're doing an on call, which is 12 hours, you get 500 pounds before tax. And if you can do that full time, you will basically be out earning a consultant. So I did that for a while. I felt like, even financially, that helped me save up. So I think as doctors, we rarely ever talk about money, but being financially savvy and saving up early in your career really does help long term. So, investing that in different things does, really benefit you. And then when I was able to choose and pick the shifts that I wanted to do, I was able to have more time and money to invest in myself. So I did that for about a year. Did my exams during that time, worked on my portfolio, and essentially when I applied, I got into a very highly competitive post. So, my portfolio was good. I just needed a little bit of, time to think about what I want to do. I always suggest having a plan B. So my plan B was just plan A again. But again, plan B was applying again or applying for ST3. So, but always think about, if this doesn't work, what else can work in that place? So that is my personal problems and my journey up till now. And I hope that, sharing some of my failures and some of my difficult times might resonate with someone who is on the pathway to get into surgical residency in the UK. So how to get started in med school and in early in your career. Publications. No one actually knows how to publish till you actually start publishing. So you just need to start writing something, anything. A case report is very simple, very easy to publish, and there's lots of papers who take case reports. So you should start doing that. Commitment to specialty, apply for observerships in a surgical specialty, apply for taste 2 weeks. just go in, introduce yourself, tell them, oh, the consultant, that I am interested in this specialty or that specialty, and offer to shadow them. At the end, take a letter from them that, I've spent 1 week, 2 weeks shadowing you. You never know where that helps you. Extracurriculars, so leadership experience. I never knew that this would help, but during my med school, I was the class president. That's what you call it in the UK, but essentially a CR. So that is leadership experience, and that actually counts over here when you're talking about leadership. Teaching experience. So if you've taught anyone, even if you privately tutored someone, that counts as well. So, saying yes to many different opportunities, you never know what will help you down in your career. Develop your skills as a surgeon. So not just practicing, but also essentially scrubbing in with surgeons. And then conferences and presentations. If you have a project, submit it to any conference. The worst they can say is no. Many conferences just accept whatever is presented to them. So get that experience.
Hello. Sorry, if you could just wrap up your presentation because we need to start asking questions so that we can wrap up this session.
Sure, I think I've already spoken about this. I've already spoken about this as well. I'll just speak about the interview. So the interview is essentially 3 minutes of a leadership speech, 2 management questions, ethical questions, and 2 clinical scenarios. So we can talk about this in a lot of detail, but essentially when you get to that phase, contact me, email me, and I would love to help anyone who needs help with the interview. And then one slide I would like to add that the landscape is changing in the UK. There's a lot of anti-immigration talks going on. And at the moment, there's no preferential treatment for the UK grads. So you are applying at the same level as them. But they are saying that they will change. They will change that. When? No one knows. I think I'll just skip this and then we can go straight to the questions because it's not really that important. But yeah, if there's any questions, you can ask now.
All right, let's start with the questions. So Zafar is asking, are there any elective opportunities in the UK?
So elective opportunities, I think what we call it an observership here. If you're talking about something you do during med school, then yes, but you'll have to contact the consultants directly. If you know someone who knows someone, it's generally easier. But consultants usually have like NHS emails and you can email them. I think there is certain observerships that go online and they basically like kind of advertise it like a job and you apply on it through like an online portal. But they are quite rare. And at the moment they are paid. So you pay like good £500, sometimes up to £1,000 to do these observerships.
All right. And would you recommend applying for surgical residency in the UK, given the recent news on low job opportunities in the NHS?
So if you're already in the UK, I would say go for it because it's better to be in a training job than a non-training job at the moment. I don't know when they'll announce this. Nothing actually happens in the UK. People love talking about, anti-immigration, but essentially, when are they going to pass this law? And at the same time, like the same things are happening in the US. The whole world is very anti-immigration right now. If UK is somewhere you want to be, then apply for it and go for it. If not, and if you think you have better opportunities elsewhere, then you should do that. But I feel like all these problems were also when I was applying, these problems have been around for a while. They just get worse sometimes and then they get better. So essentially, I would probably say like, if this is something, you want to do, then just do it. Also, the fact that, when you do PLAB, you're able to work in Australia, New Zealand as well. I think you're able to go to the UAE and you don't have to do their exams. So the lab does kind of open up a lot of doors for you. So that's also something to keep in mind.
Okay, I think that's all the questions that we have for today. So
Okay, perfect.
thank you so much, Dr. Rabeeia, for such an informative and insightful session. I'm sure it cleared up a lot of questions for many of us, and it was an absolute pleasure to have you with us today. So thank you.
Thank you so much. Thank you.